Medications for opioid use disorders in correctional settings. Shifting the paradigm, creating a balanced correctional and rehabilitative approach. The Opioid Response Network is funded by SAMHSA to provide resources and technical assistance needed locally to address the opioid crisis. This video is part of a series to provide guidance on the implementation of medications for opioid use disorder in correctional facilities. Leading corrections and behavioral health experts present information on topics such as the use of medication, models of delivery, diversion, and linkages to care and community support. An interview with Stephen Lloyd, JourneyPure Treatment Center. What inspired your passion to support programs for pregnant women?
When I first started in addiction medicine, there were two groups of people that I looked at. First of all, folks that were incarcerated. Second, were pregnant women. And at the time, living in the state I lived in, people in jails and prisons were going to be hard for me to get buy-in. It was not hard getting buy-in for pregnant women. Everybody still cares about pregnant women, so that's the route I chose initially. So I've treated well over 300 women that have been dependent upon opioids through their pregnancy, treating them with mainly buprenorphine, but some methadone and some naltrexone. And I was always amazed at the number of people that ran treatment programs that would say bad things about these women. Or they're doing this, or they're going to this place, or they're going to this place. And I always interrupt, and I'd say, well, tell me about your program that you have for them. And they said, well, we don't take them. And I found that a bit self-righteous, and I never confronted it directly. I just didn't want that to be the case. And I would have women that were found out to be pregnant while they were in an inpatient treatment program and then discharged as a result of being pregnant. And that happened numerous occasions. So when I left the state of Tennessee several years ago, the reason that I picked places to go were they were going to let me start treatment programs for pregnant women. And I've got extensive experience in it, and luckily a lot of really good folks that I work with. But one of the things that we look at really closely is one of the best ways to address this is to prevent the pregnancy in the first place at the woman's choice. We know that more than half of all pregnancies in the United States are unintended. Doesn't matter if you have substance use disorder or not. And even in the substance use disorder population, it's even higher. And so what we looked at is, where do we have a population that we have access to, that we could educate, and then at their choice, give them unfettered access to voluntary reversible long-acting contraception, not the pill, right? IUDs, implants. And the obvious place became incarcerated folks, right? And so I have a good friend, Judge Dwayne Sloan, in the 4th Judicial District in Tennessee, 4 counties. And so we piloted a couple of programs there. And this is all initiated by folks other than me. And the idea was that we would go into the jails, and we knew the at-risk population, we knew the childbearing age, and we simply educated those women on reproductive rights, modes of preventing unintended pregnancies. And then at their choosing, if they wanted it, then we partnered with the University of Tennessee at Knoxville and the Tennessee Department of Health and actually took the intervention into the jail while they were still incarcerated. And it's interesting, the very first county that was tried in, within 10 months, the NAS rate in that county, it was one of the worst counties in the state at the time, dropped by about half. And that's been maintained now. It's actually a little more than half. It's been maintained for 3 years. Almost 1 year later, the county adjacent to it, we did the same thing. And within 10 months, the same thing happened. And so there were 3 counties initially. All of them showed the same results. And then now it's spread to 55 counties in the state of Tennessee with the goal of being all 95 counties. So the best way to prevent NAS is to prevent the unintended pregnancy. And then, for those that don't fall in that category, then we have to have unfettered access to medication-assisted treatment, either with buprenorphine-based products or methadone.
What does NAS stand for?
NAS stands for neonatal abstinence syndrome, and what it is the opioid withdrawal syndrome that a newborn faces because the source of the opioid has been taken away. So it's just like you or I. If we were dependent upon opioids and we got physiologically sick, dope sick, when we stopped taking them, then we would go through a period of where we didn't feel good at all. And I've been dope sick myself. You wouldn't wish it on your worst enemy. Well, babies have that are exposed to opioids in utero. Not all of them. It turns out it's around around 60%. So it's not all. And the interesting thing is it's not related to the dose of medication that mom's taken, at least not that we can prove. And so whenever the baby's born, then the source of the opioid is taken away. And if they develop symptoms of neonatal abstinence syndrome, then they have to be, quote, detoxed with medication like morphine. In the NICU, but there's several programs now that are experimenting and showing good results with non-medication mediated withdrawal syndrome from opioids.
How does the use of MOUD support pregnant women and their babies?
So if you look in our state, and I'll talk about the state I know most about, which is where I live and work in Tennessee, most of our women that were giving birth to babies who were born drug dependent were on buprenorphine. Right. And so we actually had some folks in around, and I won't say where, that said, well, that's our problem. We need to outlaw buprenorphine. I actually sat in meetings where they talked about making it illegal to give pregnant women methadone and buprenorphine. It's the drug of choice. And so luckily that didn't come about. But one of the things is first of all, giving your patients informed consent when you start them on something such as buprenorphine or methadone. And I do that with all my patients across the board if they're childbearing age. Letting them know that if you do get pregnant, either intentionally or unintentionally, there's a chance your baby can be born dependent. Now, we can treat that, but it's also very emotionally difficult for the moms, right? The baby's born, it spends X amount of time in the NICU, you've got the separations, there's a lot of things that go along with that. But I don't want it to be to the point where they don't get treated and stay in the active substance use disorder. So I always explain to them the goals of pregnancy, right? Give birth to a healthy baby, not be involved in the illegal activity that maybe you're involved in, lower your risk of acquiring hepatitis C, HIV, those type things. And I always encourage them that they're doing the right thing. But the biggest barrier that you have are all the folks around them, right? And a lot of times it's in the hospital, nursing staff in the hospital, it's their parents, it's people that are around them. Oh, you're switching one drug for another, your baby's born dependent, you're on this medication, you just need to quit, those type things. And so it's really, really stigmatizing. And what I want to do is I want to empower my women patients. Hey, you're making the right choice. And there is a chance that your baby can be born dependent, but you're still making the right choice for these reasons. And then be open to meeting them no matter where they are. And that's voiced a lot of places, right? Oh, we're going to meet people where they are, but there's always a caveat, a but, and I'm talking nothing. Wherever you are, I don't care where you are in your life, I don't care where you are in your substance use disorder, that's where we're going to meet you, and then give them informed consent so that they can make a decision in the least stigmatizing way possible.
Do you share your personal recovery story with new patients?
Any new patient I get, male or female, I lead with my own story of substance use disorder and recovery. It's about connecting. And some of the things that I did in the depths of my addiction are horrible to even think about. Stealing medication out of people's medicine cabinet, which I did numerous times, stealing from my family. I'm so grateful that I have those things. I know that doesn't sound right, but I wouldn't take them back, because a lot of times when I have a patient in front of me that's feeling that shame and stigma, and they're thinking that they've done the worst thing in the world, that nobody can relate to it, and I volunteer that information, I can sometimes just see it come right off of their face. And now here we are, and here's where I am in my life, and I was given this opportunity, and I want to give you the same opportunity. And I'm not special, right? I'm just like anybody else. I happen to have an MD. That's it. As a result of that, I got pretty high quality treatment, but this is something that's available to everybody if we can just make that connection. So I always lead with my own story every single time. And parts of it I divulge is really patient dependent, what they're running up against. I have a history of physical and sexual abuse, and we know the importance of trauma-informed care and addiction. And so I don't share that with everyone, right? But I do share it publicly in my talks on addiction because I think it's important. And I share it with those patients who are having a hard time facing that. Now, when I do that, I need some serious help, right? I've got to have therapists that are trauma informed and can deal with extreme physical and sexual, abuse. And so that was a tricky area for me at first, because I would have that patient in front of me that I got to open up, and then I didn't know what to do with them, right? I'm not trained in that, but I've learned a lot of lessons through the years in helping folks with that.
What are you currently working on?
I told you about my friend Dwayne Sloan. So Dwayne is a state judge in the state of Tennessee in the 4th Judicial District. So he has 4 rural counties, and so it just so happens that those 4 rural counties are some of the worst counties, not only in the state of Tennessee but in the United States for opioid use disorder as well as overdose deaths secondary to opioids, now mainly heroin and illicit fentanyl. And so I heat mapped it. Through NIDA has a website, and so it shows that even by county, it'll show you the counties that are hottest in need of opioid treatment programs. OTPs are methadone treatment, and then OBOTs are buprenorphine treatment. So it shows you the counties that have the most need. Well, it just so happened that one of the counties that had the most need in the whole United States was a county called Cock County. Well, that's in Judge Sloan's 4th Judicial District, and so I went through the process for certificate of need in the state of Tennessee, which was unbelievably expensive. I've sunk my life savings into it. My retirement's sitting in that building, but we wanted the ability to deliver methadone treatment to folks that need it. Buprenorphine is a lot easier, right? We can open up practices and get those off the ground a lot quicker, and you don't have to go through a certificate of need process. But a certificate of need process takes 6 months to a year. Heavily attorney involved, so it's very expensive. And so it's usually around 6 figures before you even get the CON, and that's before you build your clinic. So we're slated to open right now in April. And the only reason I put it where I put it was so that I could be the treatment provider for Judge Sloan's Judicial District, as well as 2 wonderful sheriffs in the state of Tennessee who are going to allow us to pilot jail programs with people for access for MAT who are in county jail. And our idea is to go far upstream as possible. We want to meet them before they hit the system. And so we're looking at ways to do that, which is the reason I'm at this conference.
Did you receive any pushback when you started talking about the benefits of MOUD?
When I first came to Nashville and started talking about MAT, started talking about buprenorphine and methadone, there were talks that I didn't get to finish. I would be up, and you're vulnerable when you're speaking, right? And I didn't get to finish. The pushback, and 90% of the time that I got that level of pushback, it was from people in the recovery community. They were part of 12-step programs, and I get it, right? It saved your life, and you think everybody ought to have that. And I love 12-step support groups, but Bill W. and Dr. Bob never intended for AA or NA or any of those things to become treatment nor dogma, and they became both. And so I want to help the people find the path that's right for them. If it's that, I'm great with it. If it's other ways, I'm great with that. But I know the most effective way to keep people in the treatment process is medication-assisted treatment, or MOUD. And so when I first started talking about that, there was a ton of pushbacks. But unfortunately, people kept dying. And so one of the things that I learned early in recovery, that the definition of insanity is doing the same thing over and over, expecting a different result. And that's exactly what I was seeing. And so I started working that into my talks. And I talk about using medication as bait, because people get better with behavioral change, but you can't treat them if they're dead. So I always talk about medication as bait. We're going to relieve your withdrawal symptoms. We're going to help you with your cravings. We're going to give you some time to get your feet on the ground and have time for your frontal lobe of your brain to wake up so you can have better insight and judgment. And then we're going to start to help you with some of the trauma stuff that drove your addiction in the first place. And so when you start talking in those terms, a reasonable person will get it. Now, you're always going to have the outliers, and I can just do what I need to with that. I concentrate on the people who will keep their mind open. Judge Sloan, right? First time I met Judge Sloan, oh gosh, he had a mean look on his face anytime I mentioned these things, but he kept his mind open. And then he started putting it into practice and see what happened with the people that were appearing in front of him in court. And he changed his mind as he saw results. And then he became a huge champion and advocate. And it's one of the, well, first of all, he's become one of my very best friends. But the things he's been able to lead change-wise are immeasurable. And he wouldn't have been able to do that without keeping his mind open.
Is your treatment center tied to any local jails or prisons?
The one we're building, yes, absolutely. The whole reason I put it there was it's in Judge's Judicial District. So I'm actually going to sit on his recovery court. Okay, and I'll be a part of his regular court docket, because we looked at an initiative and we named it 10 Rocks, but it is recovery courts are intensive, right? They're great. I love recovery courts, but they're training intensive, time intensive, money intensive, and there's only so many spots. Well, one of the things I learned is I got to know Judge, and this was all his idea. When I heard it, I thought it was brilliant. Judges get to set the terms of probation and parole for everybody that's in front of them. He can tell you got to wear red socks on Tuesday. You better wear red socks on Tuesday. So the idea was that it doesn't matter if you're in recovery court or not. If you have a substance use disorder, then making that part of your probation or parole. So we can guide you to treatment. We can get you in treatment programs, and then the accountability portion of frequent appearances before the judge that you were going to have to do anyway. So from a time intensity standpoint, it's no different than it was otherwise, right? And we really don't need judges to volunteer to do drug recovery court. We don't need them to go away for training. What we need them to do is have a basic understanding of addiction and then hook them up with the people that can get their folks into treatment programs, right, locally, and then use the power of the bench to hold people accountable, not in a punitive way. And so that's what we're doing right now, and that's why I am where I am. So on Thursday afternoon, which is when Judge Sloan has his recovery court, I'm a part of that team. And I'll sit in and we'll go through the clients just like we do everybody. But now when we have patients that need MOUD, then I am the treatment provider. The thing we're looking at in jails are, one of the things I've learned here at this conference, the big blockade here in this conference are treatment providers. Right? You've got a incarcerated population, so you've got a captured audience. We can put treatment programs in place. What do we do when they walk out the door? I'm going to treat them there, and I'm going to walk them out the door right straight into what we're doing in the outpatient setting. We've got some barriers around that with the insurance reimbursement, as you know, but we're not going to let that stand in the way because I know what we're going to see. And so I'm really excited about that, but it's the whole reason for the location of the clinic.
Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorder. To request technical assistance, visit opioidresponsenetwork.org.